Thank you for inviting me to speak here today. I'm really excited to talk about cardio-oncology and CHIP. Both topics have been my clinical and research focus now for some time. So this is the outline of today's discussion. I'll start with an introduction to CHIP. I find that this is useful because it is a relatively new field, and so there's a lot of evidence and science that I think we can go over to get a good background. Next, I'll focus on one specific type of CHIP mutations, which is a TET2 CHIP mutation and its role in cardiovascular disease and inflammation, followed by looking at expanding roles of CHIP in cardiovascular disease, specifically in atrial fibrillation. In the last portion, I wanted to focus a bit on CHIP in the clinical practice. You'll see that the majority of this talk will lean more towards science and research and the basic science side of things. And this is because there's a lot of focus in CHIP and cardiovascular disease in that space. There isn't a lot in terms of CHIP in clinical practice. So we'll look at some of those barriers, what a CHIP cardiovascular disease clinic looks like, and potential therapeutics that may be introduced in the future. So I've mentioned this before, CHIP is a very popular acronym in medicine and science, and in this case, it stands for clonal hematopoiesis of indeterminate potential. We know that CHIP mutations are very common, and by the age of 70, about 20% of healthy individuals, these are individuals who don't have any abnormalities in their blood cell counts, who don't have any heme malignancies or any signs of overt malignancies, 20% of these individuals will have CHIP. So what is CHIP and what is clonal hematopoiesis? So somatic mutations occur in blood cells or proliferating cells, and this occurs over a lifespan, and this is a normal process. The majority of these mutations are inconsequential. However, mutations in a specific subset of genes, including DMT3A, TET2, ASXL1, JAK2, SF3B1, P53, and PPM1D, can lead to clonal proliferation and thereby a survival advantage and clonal expansion of those cells. So while there are over 70 known CHIP genes that can be mutated, the ones that I listed are the most dominant, and they make up over 70% of known CHIP mutations, the majority of which are DMT3A and TET2. And when we look at these genes, we see a variety of cellular functions. These include epigenetic modulators, chromatin modulation, tumor suppressor genes, tyrosine kinase genes, as well as other functions. So we see that there's a wide variety of molecular and functions for these genes in the cell, and thereby showcasing that proliferative advantages are indeed opportunistic. So by definition, the current diagnostic criteria for an individual who has CHIP that they have to be healthy. So as I mentioned, no signs of a malignancy, no abnormalities in their CBCs. They also have to have a burden of these CHIP mutations at about 2%, so a variant allele frequency of about 2% or higher. So what happens to the majority of these people who have CHIP mutations? As I mentioned, most of these are inconsequential, and those that develop CHIP and clonal expansion also don't really develop any disease. However, there is a process where clonal evolution can occur, and that's the accumulation of a secondary mutation or cooperating mutations, and this includes gene or mutations in genes including RUNX1, KRAS, and STAG2, and this can lead to malignancy progression, including MDS or myelodysplastic syndromes and leukemias. So it makes sense that individuals with CHIP have an increased risk for developing cancer and increased risk of death. And if we look at how we can risk stratify patients with CHIP, we can actually put them into 3 different groups: low and intermediate and high risk. So when we look at what defines these 3 different subgroups, this was actually taken from a study in a paper that looked at large cohort studies using UK Biobank and EMR patient data from Dana-Farber. And they were able to determine what these characteristics are that makes a person low, intermediate, and high risk for CHIP progression. And they're quite intuitive. We see what this model is based on. We see patient characteristics such as higher age. They may have changes to their blood cell counts like RDW and MCV. they'll have more than one mutation, and more importantly, they have high-risk mutations, and they have to have a single DMT3A mutation. This risk score is helpful in the heme world because it allows providers and specialists to further stratify patients who have CHIP as to who needs more surveillance, if any additional tests are required, and also provides some reassurance to patients when they have CHIP mutations in terms of, will I develop cancer? I think as we move forward, this risk score will actually gain more granularity as we learn about clonal expansion and evolution as well. So we'll see different factors playing a role in how we stratify patients with CHIP. And so, of course, as with everything now in 2025, there is an app and a website that can help you calculate this CHIP risk score, and I've listed it here. There's no such risk score in the cardiovascular world, which is quite interesting. When we look at the risk for death for individuals with CHIP, we see that there's about a 2 to 4-fold increased risk of death if the person has CHIP. But if we take a look at their increased risk for developing cancer and their risk of developing hematologic malignancy specifically, we see that that risk is about 2% per year. So we can't fully explain the risk of death associated with CHIP to that of hematologic malignancies and cancer-related deaths. So we now know that that increased risk for death is related to cardiovascular disease and cardiovascular outcomes. And this is taken from a paper from 2014 New England Journal from Sid Jaiswal, where he's able to show that individuals in 2 different groups, so less than age 70 or greater than age 70, had an increased risk or a decreased survival compared to patients who did not have CHIP. So again, looking at large population studies, what is the risk of developing cardiovascular disease if you have CHIP? And it's about 2-fold increase of risk for incident coronary artery disease and stroke. And so when we subdivide this further, we look to see that different CHIP genes actually carry a different risk for developing coronary artery disease and stroke. If we take a look at the very common genes like DMT3A and TET2, we see about a 2-fold increased risk for CAD and stroke. But if we take a look at another gene, JAK2, we see the highest increased risk, about 12-fold increased risk. So again, showing us that CHIP gene and the specific CHIP gene matters in terms of your cardiovascular risk. We also know that the higher the CHIP burden or the higher the variant allele frequency, the greater the risk for developing coronary artery disease and stroke as well. This also correlates nicely with the CAC score. So when we look at the coronary calcium, we can see both the burden of atherosclerosis and also give us some prognostic value to individuals who have a higher score. If you have CHIP, you have an increased risk of or increased prevalence of a higher CAC score. But most importantly, if you had a higher variant allele frequency, that risk increases. So we do see a nice association in humans that having CHIP increases your risk for developing coronary artery disease. It correlates with a higher CAC score, and this is associated with increased mortality. Can we also see this in mouse models and show causation? And the answer is yes, we can. Mouse models nicely support our human observations and give us more evidence for causality, specifically for TET2 CHIP leading to coronary artery disease. So these are transplant mice with hematopoietic specific loss of TET2. And these mice are on a background of LDLR deficiency, so they're proatherogenic. And after being fed a Western diet or a high-fat diet, we see that at 9 weeks, these mice develop greater aortic plaques at the aortic root. And this is more prevalent in mice that have loss of TET2 in their hematopoietic stem cells. And this is its quantification. Similarly, do we see any downstream effects for coronary artery disease in our mouse model like heart failure? And the answer is yes, we can. In a post-LAD ligation model for ischemia in the same mouse that we're using for our TET2 CHIP, we see both increase in fibrosis in the myocardium and a decrease in the ejection fraction that signifies an increased risk for heart failure as well. So do we also see this increased risk for heart failure in humans? And the answer is yes, we can. This is a cohort of 200 patients who had stable coronary, stable heart failure, and a history of coronary artery disease, so prior MI. And they were followed for at least 3 months. These patients were followed for an entirely different study. I believe it was looking at cardiac stem cells. So there was a lot of genetic data and sampling that was collected at the time. I think that study ended up being non-productive, but it was reutilized for this CHIP study. And they were able to show that, again, the predominant mutations in these groups were TET2 and DMT3A. And individuals who had these mutations actually had worse outcomes and increased risk for death compared to individuals who did not have TET2 or DMT3A mutations. And if we further stratify them by their variant allele frequency or their clonal size, we see that individuals who had larger clone size, so greater than 2% VAF, had an increased risk for poor outcomes and decreased risk for survival. But if we look at individuals who don't technically have CHIP, so these are individuals with a variant allele frequency of about 1 to 2% or even lower, we still see an increased risk, although not statistically significant, for death. And so it again shows us that we can even further risk stratify precursor disorders in the CHIP state as well too. So how can we tie together what happens at the hematologic level? So what happens in hematopoietic stem cells, linking it towards cardiovascular disease? One unifying pathway is increased inflammasome or inflammation. So we know that inflammation is tightly linked to coronary artery disease. This has been a study that my prior mentor and my current mentor, Peter Libby, has been focused on. And we know that mice, in our mouse model, mice with hematopoietic specific loss of TET2 have increased pro-inflammatory cytokine production. This is a heat map taken from bone marrow-derived macrophages cultured with stimuli of LDL, and we see an increase of inflammatory cytokines as seen here in this sort of red predominance. But we also see an increase in IL-6 and IL-1 beta production as well, and that's most notable here. Can we also see this in humans? And the answer is yes, we can. So individuals with CHIP have also elevated pro-inflammatory cytokines such as IL-1 beta and IL-6. So this is taken from the UK Biobank of about 30,000 patients with prevalent cardiovascular disease. And we looked at whether or not DMT3A and TET2 mutations had an increased risk or had an increased association with IL-1 beta and IL-6. And we see that it's most prevalent or most predominantly seen in TET2 patients. Further to that, we see evidence that pro-inflammation and cytokine production, particularly IL-6, plays a role in patients who have CHIP. So there's a specific mutation in the IL-6 receptor that makes these patients less sensitive to IL-6 signaling. So this is the mutation aspartate 358 alanine. This is a known variant, and it's actually quite common in the population. Again, utilizing the UK Biobank, this is actually a paper done by Alex Bick and James Pirotello, who's here on faculty. They showed that individuals who had this particular IL-6 receptor mutation actually were protective against the increased risk for cardiovascular disease in patients who have CHIP, and that's seen here in this dotted blue line. So can we also see that in mice? Is reduction of inflammation protective in TET2 CHIP mice? And the answer is yes, it is. So when we look at hematopoietic specific loss of TET2 in our mouse model, if we inhibit that with an inflammatory or an inflammasome inhibitor called MCC950, we see a reduction in atherosclerotic burden. This is actually a replication of a table or figures that I'd shown previously. Here we see that increase in aortic root size in our TET2 CHIP mouse. But when you add MCC950, we see that reduction of increased aortic root burden. Again, we know that if you have TET2 CHIP mice and you give them LAD ligation and you look at them post LAD ligation, there's increased fibrosis and also a decrease in the ejection fraction. But if they're treated with MCC950, you no longer see that reduction in EF, and that's seen here when you compare the gray bar to the red bar. So now we have a nice background of what is CHIP, how is CHIP affecting cardiovascular disease, and what specific mechanisms are in play. And we know now that there's a great role for inflammation and specifically inflammasome activation that leads to an increased production of IL-1, beta, IL-6, and even some evidence to show IL-18. This leads to increased plaque formation, increased atherosclerosis as well. There are other forms I mentioned JAK2 briefly, but we know that JAK2 has a different pathway in terms of how it affects cardiovascular disease, mostly through net formations, which are increasing in thrombotic events. And so we see that these molecular events, or these events that are occurring in hematopoietic stem cells, eventually lead to a variety of different cardiovascular diseases. Again, we started off with stroke and coronary artery disease, atherosclerosis as well. And I didn't present the evidence here today, but we also have strong evidence in both human and mouse models that CHIP plays a role in peripheral artery disease, including roles for DMT3 and TET2, and most interesting, a role for P53. We talked about CHIP and its role in heart failure, mostly ischemic heart failure, but there's also evidence for non-ischemic heart failure as well. There's some potential evidence for a role of CHIP in pulmonary hypertension, again, a topic that we'll leave for exploration at a later point. And today, I think we'll focus on atrial fibrillation, which has been some of the work that I've been involved in over the past few years. So a very unnecessary slide for this group, but just briefly on atrial fibrillation, it's the most common tachyarrhythmia worldwide. This is looking at the burden of atrial fibrillation spread out over different areas of the world, including Western and developing worlds. And we see that by 2050, so not too long from now, we can see an increase in prevalence ranging from anywhere of 2 to 10-fold times. So extreme high morbidity, and associated mortality associated with atrial fibrillation. This is a fact that I always found a little mind-boggling, but I think it's confirmed. The lifetime risk of atrial fibrillation is about 1 in 4 after the age of 40, so highly prevalent as well. When we look at the causes of atrial fibrillation, it's multifactorial. These also relate mostly to atherosclerosis, ischemic heart disease as well. We can look at metabolic derangements as well as hemodynamic alterations and structural changes that can lead to the pathogenesis of atrial fibrillation. But if we look more at the molecular level, we're beginning to understand that pro-inflammatory states also play a role in atrial fibrillation pathogenesis. We know that patients with chronic atrial fibrillation have pro-inflammatory markers that are elevated, and these include IL-1 beta, IL-6, TNF as well. They have elevated markers of inflammation such as CRP. And again, I'll be presenting some other data that links NLRP3 or inflammasome activation and the pathogenesis of atrial fibrillation as well. So the question that we had is, does CHIP affect or increase the risk of developing atrial fibrillation? And specifically, does TET2 CHIP increase that risk? And so hopefully you'll agree with me by the end of the work that I present here that it does. So this is looking at UK Biobank at the incident atrial fibrillation in patients who have CHIP. And we see that there is a modest increase, about 1.3 in terms of its hazard ratio. So not that high, but when we stratify these again by specific CHIP genes, we see that this increased risk goes to about a hazard ratio of 1.3. So the CHIP gene matters. And more interestingly, the most common CHIP gene, DMT3A, actually does not have an increased association for developing incident atrial fibrillation. Other genes such as ASXL1 and JAK2, we didn't have enough in terms of patient samples in this particular group to find any significance, but there was some evidence to show that there may be an increased risk in other genes as well. Our focus stayed with TET2. And so we wanted to see if loss of TET2 actually increases AF inducibility. And the mouse model is a tricky one to do this in, as mice do not develop de novo atrial fibrillation, but you are able to stimulate them in terminal EP studies that look at rapid burst pacing as a way to induce atrial fibrillation. So this is that same mouse model that we talked about. So these are recipient proatherogenic LDLR deficient mice transplanted with bone marrow derived from either wild type or hematopoietic specific loss of TET2. And these mice were fed a Western diet. And then EP studies were performed. And we can see that these mice do develop sort of like an A-flutter type arrhythmogenesis here. We see that with mice that have loss of TET2 and hematopoietic specific lineages, there's an increase in both the number of mice that develop atrial fibrillation as well as the number of actual events that occur. So the number of AF inducibility increases as well. If we look at the substrates for AF inducibility or susceptibility, we can see that there's a decrease in the effective refractory period as seen here in our TET2 deficient mice, and also a decrease in the action potential duration. And these have been linked to increased risk for developing atrial fibrillation. What's also notable is that when we look at the atria of these mice, we see that they have an increase in NLRP3 expression. And what we should remind ourselves is that these mice only have a perturbation of loss of TET2 in hematopoietic lineages. The cardiomyocytes are in fact normal, if by normal you mean proatherogenic in an LDLR deficient background, but essentially normal in terms of what we're using in terms of our mouse model. So I had mentioned previously that NLRP3 inflammasome activation has been linked to promote electrical remodeling and atrial fibrillation, and this was done by the Lee group out of Texas. And so we wanted to see if inflammasome activation played a role here in TET2 specific loss, hematopoietic specific loss in our mouse model, and indeed it does. So we used both a genetic ablation and also a pharmacologic inhibition to showcase that. So here on top, we took mice that are now recipient deficient in NLRP3, so the cardiomyocytes no longer have NLRP3, and our bone marrow donors are both either wild type or have loss of TET2 in hematopoietic lineages. We see that we can no longer see that increase in atrial fibrillation inducibility in terms of the number of mice and the number of events, and we also don't see any alterations in the susceptibility factors, including effective refractory period and the action potential duration. When we took a specific inflammasome inhibitor, so this is an NLRP3 small molecule inhibitor that was generously donated to us by Novartis, and we fed these mice this inhibitor in their Western diet. And these are mice, again, that are LDLR deficient, so they have normal NLRP3 in both their hematopoietic lineages and also in their cardiomyocytes. We see that we no longer see that increased risk of AF inducibility in terms of the number of mice and the number of events, and there's no change in the effective refractory period and the action potential duration. So this demonstrates nicely that there is a necessity for recipient NLRP3 activation for AF inducibility in our TET2 chip model. So next we wanted to look at what is actually happening at the level of the cardiomyocyte in terms of, and specifically looking at calcium handling. We know that calcium handling is linked greatly to both the electrical activity for the cardiomyocyte, but also AF inducibility as well. One of the key regulators is CAMK2, and when we isolate cardiomyocytes from our mouse model, we see that there's increased expression of CAMK2. And this is a key component for both calcium release from the sarcoplasmic reticulum, as well as regulation through ribine receptors as well too. So when when the cardiomyocytes are paced, we see that there's an increase or release of calcium as seen by these spikes here. And when you stop that electrical pacing, there's no longer any release of calcium. So this is what we expect. But in our cardiomyocytes isolated from our TET2 deficient mouse, we see that after you stop electrical stimulation, there's still spontaneous calcium releases as indicated by these red arrows. So this indicates that there's aberrant calcium handling in these cardiomyocytes, and this is just a quantification of those calcium release. If these cardiomyocytes are treated with caffeine, we can then see the change in the calcium release as well from the sarcoplasmic reticulum. So these calcium induces total release of calcium from the sarcoplasmic reticulum, and that can be quantified. So this is what you would normally expect after you incubate these cells with caffeine. You see a large release of calcium. But here in the TET2 deficient mouse model and cardiomyocytes that are isolated from these mice, we see a delayed response. And this indicates that there is, again, abnormal calcium handling from the sarcoplasmic reticulum and release into the cytosol. Can we recapitulate this at the level of within the cardiomyocyte and what actually stimulates this? We know that from previous work out of the Narendarov group at Mass General, they emphasize the importance of macrophages, and particularly cardiac macrophages, affecting electrical conduction, both in terms of heart block and in facilitating atrial fibrillation. So we wanted to see if we could also show this, if there are changes that we can see in calcium handling when we co-incubate bone marrow-derived macrophages that have loss of TET2 with our cardiomyocytes. And in this case, these are iPS-derived cardiomyocytes. And again, we repeated calcium studies, and we see that decrease in the calcium release upon the addition of the stimulation with caffeine. And then again, this is the quantification of that, both the calcium release and also a decrease in the calcium transient amplitude. This actually shows us that we can recapitulate this if we add cytokines. So is it the interaction of the macrophage alone, or is it the release of pro-inflammatory cytokines? And when we incubate our macrophages, when we incubate our cardiomyocytes without any macrophages, with IL-1 beta and IL-6, we do see a decrease in the calcium transient amplitude as well. So both in our vivo models and our in vitro models, we have demonstrated nicely the contribution of both mutated immune cells, particularly with loss of TET2, that contributes to atrial fibrillation and also electrical changes and alterations in calcium dynamics that can lead to what we see in terms of atrial fibrillation inducibility. So let's go back again to some of the things that we're talking about in our first few slides in terms of CHIP as a risk factor for cardiovascular disease. So we have shown that now CHIP is a known risk factor for cardiovascular disease. It can affect both atherosclerosis, heart failure. We talked about how it also affects peripheral artery disease. I've demonstrated our evidence that shows that it's also a factor in atrial fibrillation and arrhythmogenesis. How does it compare to our known traditional risk factors? So when we actually line them up and we look at the presence of CHIP, increased risk is about twofold. And that's comparable to some of our well-known traditional risk factors like high cholesterol, hypertension, former smoking, and really only outpaced by diabetes and age. So it's a potent independent risk factor comparable to our known traditional risk factors, and yet we're not really using it very well in our cardiovascular disease clinics. So what does a cardiovascular CHIP clinic look like? So we're building one here at UCSF. And again, as I mentioned, despite the growing evidence of the role of CHIP in cardiovascular disease, testing for CHIP is not yet part of the standard of care in cardiovascular disease. Testing for CHIP is a standard of care in hematological diseases. Even in the precursor disease, you can actually test patients who have cytopenias. You can look for patients who have an increased risk for developing MDS and sequence them for CHIP. And these can be individuals who've had a prior tumor, so like a solid tumor, for example. And this is all part of standard of care in that setting. But again, not part of the standard of care in cardiovascular disease. That being said, we know that without testing, we can't have a robust registry of patients who have CHIP and also no biobanking. So limited studies for looking at human population and natural history studies for CHIP in the cardiovascular disease setting. So what are some of those limitations and challenges? Well, I think one of the biggest challenges for introducing CHIP as a risk factor in cardiovascular disease clinics is the lack of sequencing. And so what are some of those challenges for sequencing? And I've identified what I think are the three most common or the most prevalent ones, and that would be cost. You know, CHIP sequencing has come down in terms of cost significantly over the past few years, but still that is a great barrier. Patient awareness is also another factor, and the lack of targeted therapies is the other. So I'll go into these briefly as well. So this is our timeline for a number of different things, but I think it highlights quite a few interesting factors. One, if we look at CHIP as a field and CHIP in cardiovascular disease, it's relatively new. The first paper was again published in 2017. So we're looking at a phenomenon that's really only been studied over the last 8 or so years. So it's a relatively new field, and it's made quite a number of leaps and bounds, I think, in terms of how we're looking at it in terms of a risk factor. But if we take a broader step back and we look at genetic sequencing in general in the cardiovascular disease setting, we're looking at single gene mutations as part of standard clinical practice. It dates back to about 10 to 15 years, really introduced as part of guidelines in about 2016, and even polygenic risk scores, which we've known about since about 2019, not regularly used in our cardiovascular disease clinics. So again, we're looking at a new field as well as a new field that's not commonly using genetic testing as part of its toolbox. When we look at the flip side, in our hem-onc clinics, genetic testing and risk stratification using genetic testing has been used for decades now and is part of common standard of care practice. So I think part of the integration of CHIP sequencing will take off in the future as we develop better screening techniques and also more cost-effective techniques. Again, if we're looking at sequencing, if we look back in the history, whole genome sequencing used to cost tens of thousands of dollars, and now we're down to about hundreds of dollars if we're looking at it from a research advantage standpoint. If we're looking at specifically next generation sequencing, which is what our modality of choice is for CHIP sequencing, we see that there are a number of different currently available sequencing choices that we have. Here at UCSF, we have a myeloid multi-gene panel, and out-of-pocket costs, which would be the case in our cardiovascular disease clinic, it's about $1,000 per patient. Commercial sequencing is not that much cheaper, but can be. The range is quite variable depending on which provider you look for, and that can range from about $300 to $2,000 as well. And again, these are out-of-pocket costs for our patients. If we're looking at the real costs, because out-of-pocket costs, I think sometimes are slightly manufactured and maybe overinflated. But if you look at the real costs, we can look at our research-based sequencing tests that exist. And these are looking at just the bare samples. What does it cost to get all the reagents together, the cost of the machinery, et cetera. We now have very low cost and very effective sequencing options, including one that we're pursuing out of Vanderbilt that can provide CHIP sequencing using a hybrid capture targeted panel that the cost is about $6 per sample, and it can vary up to about $20 depending on the preparation of your DNA. So we're really looking at very cost-effective sequencing options in the future, and these research-based tests are really just a step away from developing into clinical-based testing as well. So I think cost is a feature that will soon be a barrier that we can overcome in the next few years. But again, as I mentioned, this is a relatively new field of study. CHIP has only been in terms of our viewpoint in cardiovascular disease over the last 8 to 10 years or so. What do patients know about CHIP? And we don't really know because there aren't many studies that look at patient understanding of CHIP and CHIP as a risk factor for cardiovascular disease, which I find is fascinating. But we can look to our friends again in the hem-onc space to see what the appetite is from a patient perspective in terms of CHIP sequencing. A really interesting group that was focused on from this study was looking at breast cancer survivors. So we look at breast cancer survivors in general. These are typically young women who develop breast cancer, and so their chance or their risk of death is no longer linked highly to breast cancer, but cardiovascular disease. The treatments for breast cancer have become so powerful and effective that these women are not dying of breast cancer, but in fact dying later on of either secondary cancers such as AML and MDS, for which they have an increased risk for, and also cardiovascular disease. Interestingly, these women also have an increased risk of developing CH mutations. They're slightly different from the common mutations that we see related to cardiovascular disease, but still CH mutations, and they tend to be more related to P53 and PPM1D. So this is a really great population to study what is the patient understanding of CHIP, what their appetite is for CHIP testing and also therapeutics for CHIP, knowing that they have an increased risk for cardiovascular disease as well. So this survey was done out of Dana-Farber, and they looked at the survivor population for breast cancer survivors. And this is, what we expected from that group. Only 6% of these women had ever heard of CHIP. So they had no idea that there was such a phenomenon, that they had an increased risk of developing CH mutations, and they were more at risk for developing heart disease and potentially due to actual CHIP mutations. So when they were given this information, of these same breast cancer survivors had no idea what CHIP was, 77% of them wanted CHIP testing. And that actually increased to 85% if they were also offered CHIP testing with follow-up and management in a CHIP specialty clinic, or if they were offered potential treatments. What is not interesting, or actually it's still interesting but not favorable, is that if they were not offered any treatments, if they were told there are currently no treatments available for CHIP-specific cardiovascular-related risk, they actually felt like they didn't want to have CHIP testing. So that fell to about 78% again. But I think the key factor is, it is not a widely known phenomenon in terms of risk for cardiovascular disease, even within a group that has an increased risk for developing cardiovascular disease. And it's a highly sought after test in these groups of patients if they understood their risk. So definitely an area that needs to be studied in cardiovascular disease as well. So if you recall this same timeline that I had up probably about 2 slides ago, I left a rather cryptic gray bar or gray description here in 2022 about potential therapeutics that arose at that time. And so here I fleshed it out a bit more. There was a study that came out as a sub-analysis study looking at the CANTOS trial and the use of anti-inflammatories. So we spoke a lot about the use of anti-inflammatories, specifically inflammasome inhibition, to combat the effects of the increased risk for cardiovascular disease in patients who have CHIP. So the CANTOS study was published about 5 or 6 years ago, perhaps even more now, that looked at the role of IL-1 beta inhibition through the use of a monoclonal antibody that targeted IL-1 beta, so canakinumab, in patients with known cardiovascular disease and also had elevated high sensitivity CRP. So this was done out of Paul Ritker's group, and he has focused his life on looking at the effects of inflammation and cardiovascular disease as well. And he's able to show in this specific population, so again, patients with known cardiovascular disease, and also had an elevated marker for inflammation with high sensitivity CRP, there's improved cardiac outcomes by about 15% compared to all comers. So quite a significant improvement in outcomes if we look at a specific targeted therapy. What I think is more interesting is that a couple years later, a sub-analysis was done that looked at this particular CANTOS population, so again, patients with known cardiovascular disease and high sensitivity CRP elevation, and they looked to see what proportion of these patients had CHIP. And in fact, there was actually quite a high proportion. And if you recall the predominance of CHIP, mostly it's DMT3 and TET2, in this particular population, the most prevalent CHIP mutation was TET2, not DMT3A, which may indicate that within a cardiovascular disease population, there may be a selection for TET2 that may be better responders. So if we look at the sub-analysis, individuals with CHIP, particularly TET2 CHIP, had an even greater risk of developing MACE or poor cardiovascular outcomes, so about twofold. And if they were treated with canakinumab, which is the antibody against IL-1 beta, they had an enhanced response, and it was 64% improvement in cardiovascular outcomes. So this is 64% as compared to 15% in the original CANTOS trial analysis, so a greater response. So this highlights a number of different things. One, I had previously mentioned that when we're looking at a specific population, we can select for particular TET2 CHIP populations that may have a better response to treatment. And we can also then define that TET2 CHIP can be a biomarker for selection of at-risk patients that have a better response to specific treatment. Unfortunately, we don't see any patients being treated with anti-IL-1 beta therapy either in the cardiovascular setting or with patients with CHIP. And that's because the FDA, after looking at the CANTOS trial, decided not to approve it for use in the cardiovascular space. There are a number of different factors. We can talk about this at length at any other time. But ultimately, when we looked at the CANTOS trial, there was a number of adverse effects that they couldn't mitigate. So these are increased risk for infections, particularly cellulitis, sepsis, as well as pneumonia. And these were also linked to increased risk for developing neutropenia and increased mortality. So ultimately did not pass the litmus test for FDA approval. So where does that leave us now in terms of our CHIP cardiovascular disease clinic? What do we do with these patients? Well, right now, as I mentioned, we're looking at a multidisciplinary clinic. So we have a sister clinic in the hem-onc space. It's a precursor hematology clinic where they're screening for patients who have potentially, say, a cytopenia and they're found to have CHIP. They may have a prior solid tumor and they're undergoing screening for genetic markers and they're found to have CHIP as well. These patients may also have overt malignancies like MDS and AML. I didn't talk about it here, but individuals who have MDS and AML, but also have mutations like TET2 and DMT3A have increased cardiovascular risk. Those patients are being referred to us in our CHIP cardiovascular disease clinic for management and care. So they're going through a number of different tests, and essentially they're getting care for their known cardiovascular disease if they have it, and aggressive care for any cardiovascular risk factors. What about our study? So we're introducing CHIP sequencing through our research study, a registry, and a biobank as well. And so we're hoping to get a group of individuals who actually have CHIP. So these are true CHIP patients where we can provide both a study and a natural history study for these patients as well. Part of our research efforts also include looking at understanding what patients' perspectives are on CHIP and getting their understanding of what CHIP sequencing means and potential targeted therapies. And so currently, we're having more of a referral from the hem-onc clinics to our CHIP cardiovascular clinics, but in future, it'll be a reciprocal referral process between these two clinics as well. This is a website link for our UCSF CHIP clinic that provides both providers and patients with a background on what is CHIP and some of the focus of our CHIP cardiovascular clinic. And referrals can be made through our cardio-oncology Apex site with a CHIP clinic referral button to make it easier for everyone. And then again, hopefully we'll have up and running our research study to sequence CHIP patients in our cardiovascular disease clinic soon. So I will end off there. And I just like to thank the members of our cardio-oncology group, also members of our CHIP study here, Jeff as well, who is both our division leader and also helping spearhead the CHIP cardiovascular disease clinic and sequencing, former lab members from the Ebert lab, and collaborators that I've worked with, past, present, and future, and of course, our partners at Novartis as well, who've been very generous with providing us with the NLRP3 inhibitor. And I'd be happy to take questions.